put it on mute. Yeah, come on mute.
Hello everyone, thank you for coming. I don't know if Sarah wanted to wait another couple of minutes, but we are recording it so they can always watch back. So today's Lunch and Learn webinar will be on how to prescribe ONS appropriately, and we'll be doing lots of different webinars throughout the year. Please feel free to add in your comments and requests on particular topics or things that have come up with your patients in your practice for challenging conversations that you've had and where you've been a bit stumped and not sure what you should be doing next in terms of ONS. Those are the kind of webinars that we want to really be hosting. But today's will be just an overarching overview on how to prescribe ONS in the best way. And we wanted to start off with just giving a reminder for part of the PQS target, which was the standing operating procedure. It's will give an additional 5 points for the PQS target if you are participating this year, and the deadline is not that long, 30th of June, just a few days away. We have received a lot already. Thank you for those. We're just to make it really clear, you don't have to follow our guide. You can follow your own guide. It's just there for prompts and suggestions. But if you prefer a flowchart, or if you prefer any other way of doing it, or slides, or however you think works well in your practice, that's absolutely fine. And we'll give individualized feedback to each practice. So the standing operating procedure is just really to help you support patients to transition, perhaps if they're coming out of hospital, or if you've received requests from dietitians or other healthcare professionals, and making sure that it's aligning with the Bob formulary and making sure it's also appropriate, which is what we're talking about today. So with no further ado, just another aside on the standing, just an aside on tube feeding. There have been some Nutricia have been emailing us as part of the contractual process. They email us when they haven't yet received an authorization for an enteral feeding script. So we used to go through Abbott hospital to home, and we transitioned in the last few months to Nutricia homeward service. We have added a link into the slides for how to send scripts to the Nutricia homeward service, just to make it clear, as it's just slightly different to what you might be used to with Abbott processes. And what might also be helping your stats for PQS will be to make sure that these scripts are sent to Nutricia, because sometimes when we collect the data, we exclude any patients where they've had their nutrition products dispensed by Abbott and Nutricia to try and be more fair. We don't want tube feeding, they're needed, but we look at ONS and we want to make sure we exclude the ONS that's used for tube feeding. However, there is not a way with the data to exclude where patients receive their ONS for tube feeding, but they get them picked up from their local pharmacy. There's not currently a way to do that on the data, so those ones get included. We know that's not a huge proportion, but if you make sure you're up to date and familiar with how to send a script to Nutricia, then you'll know that safely that won't be affecting any compliance stats for measuring what we're measuring with PQS this year. And just a reminder where we're hosting the formulary, so you might find it on Net Formulary as the PDFs at the top. It's linked in each individual product, and then we also host it on our public facing website, and the links are there. And all our other nutrition guidelines like CMPA and gluten-free, etc. And then just a reminder of where you can find all our nutrition resources. A little bit hard to find, so I've put in the link directly there. So if you click on that link, it will take you right to where it says Nutrition Food First Resources. Otherwise, you have to scroll down. So how to review ONS. So I've linked in here to a flowchart that we did. This is our quick guide. It was renamed recently, but you can still use the same link. But this is just the quick guide to malnutrition and how to review ONS. So we'll be going in a little bit deep dive today. The first step will be identifying your patients on ONS, and they might come through different avenues. You might have had use our EMIS enterprise search to highlight people on particular products. You might receive a patient in your clinic and there'll be a conversation around ONS. It might be from a letter from the hospital or from another healthcare professional. So we'll obviously talking more about the PQS products, but these this year are the Ensure Plus milkshake style, Ensure Compact, spelling error, sorry, Ensure Plus juice, Fortisip Compact, Fortisip Compact protein, and Fortisip bottle. So your first step will be wanting to make sure if they meet any of your technical exclusion criteria, so where you don't really need to change them. They need, because They might be under an active dietitian care, so they've been seen within the last 6 months and are due to be seen again. They might be having their ONS via tube. And they might have those sorts of conditions where messing with their regime would cause them distress. So any particular mental health conditions, certain eating disorders, certain learning disabilities are not a blanket. It's up to you to really know your patients to see if having that conversation is appropriate or not, or whether they should just keep going because they're complying and everything's stable and you don't want to mess with that. And then also if they're on thickeners, certain products have to be the right IDSI level for them, so you might want to seek our advice on that one, or refer back to the community dietitians if it's not clear if the product that they're on is appropriate for their thickness level. So for those ones, we just encourage making sure it's documented, that you've had a look, you've had a review, and it's not appropriate to change. So that, because we're not doing spreadsheets this year, you'll be happy to know, but we, at the end of the year, perhaps if your compliance statistic isn't improving how you think it should, because you have been looking and you have been checking, then by having your documentation in place, then we can have a look at it. And we're always fair. We'll, we're not mean. We'll make sure that it is, we agree, and we'll offer extra support if needed. So if you've got through that stage, it's not excluded, it's actually time to review them. Then first step is always must. It might be not something that you are confident with, so we are going to give that an overview today. So that overview will include use of the must tool and what the different categories mean. So first step will be to collect your weight history for the patient themselves. If you don't have weight history, it might be that they need to arrange a face-to-face appointment at the clinic. If they can't come to the clinic, they might need to be weighed at home. If they can't be weighed at home because they have mobility issues, if possible, they might need a district nurse visit to do the mid-upper arm circumference, which we'll come to in a couple of slides' time. And then you also want to know what their weight has been doing in terms of the history. So a common misconception about this is just picking the oldest weight, but we really want to see that holistic picture. Has their weight been going up and then down? Has it been a steady going down? Is actually they lost weight 3 years ago, but they're quite stable? So really, what's the picture for that patient? And then also, if you can't weigh them, you might be able to just have a good look at them, because weight loss can be seen at different parts of their body. So around their neck, it gets sunken around here. They get sunken in between their thumb and palm, sunken cheeks, sunken around the eyes, loose jewelry, loose dentures, loose clothing, tighter belt buckles, energy levels. There's lots of different things that can contribute to their malnutrition, not just the number on the scale. We've linked there to the Bapen tool, so that can automatically plug it in for you, so you don't have to be great at maths. And then in terms of what the Bapen tool is doing, or what the must score is doing, it looks at 3 different elements. So the first step is looking at BMI, that is body mass index, and that is a measure of their weight in kilos against their height. So kilos divided by height again, and it gives a score. So if they're over 20, then that's healthy, not so worried about risk of malnutrition, they would get a score of 0. If they're between 18.5 and 20, that score's 1. And below 18.5 is the highest score, and that's 2. That's where there would be more cause for concern. You then combine that with their weight loss score. So I was saying about looking at how much weight they've lost in the last 3 to 6 months. You want the most weight. Don't just pick last month's or what it was 6 months ago. Look for that peak weight that it was in the last 3 to 6 months, and then use that one as the highest, and then the most recent one, and find out what that is as a percentage. The Bapen tool again can do that for you if you're not as confident with the math side of things. And then if they've not lost much or they've gained weight, then that's the lowest score of 0. If they've lost 5 to 10%, that scores 1. And more than 10% is cause for concern, definitely, and that is a score of 2. And so you add those scores together to get your must score. There's also step 3, but in community, you don't really need to worry about it, because that's when someone is acutely ill, not eating, really poorly, and they look like they're not going to have eaten for 5 days because they're so poorly. Unlikely. It's not unheard of, but unlikely to be a score that you need to be adding on for patients out in community. So I mentioned the mid-upper arm circumference, also known as MUAC. There are videos and everything to help you do that, but it's getting a tape measure and measuring that full length from the top of their shoulder to the bottom of their elbow, and then finding that mid distance and then wrapping the tape measure around at that point. And there are the Bapen tool can tell you which kind of measure to look for. It's not as precise as the BMI, but it will give you an indicator if they're underweight or a healthy weight. And I've already mentioned the other signs that you could look out for. And then it's not just about, as I said, it's not just about the number on the scale, but also about how they're doing. And it might be these underlying causes of why they might be losing weight. So they could have been having a recent illness. They might have things that are affecting their appetite, like feeling sick all the time, or being constipated, having diarrhea, having taste changes or a sore mouth, perhaps of treatments. They're having medication side effects. And perhaps it's a practical thing. They're not as able to stand up in the kitchen. They're not as dexterous. They can't open packets. They're struggling with, opening packets, the packet of milk or the lids on bottles. All these things we can take for granted, but they can all contribute to why someone will be eating less and deteriorating, and they might not feel able to talk about it. So gently probing and prompting, or asking their relatives to just figure out and get to the bottom of why they're actually losing weight in the first place, because we need to address that. Otherwise, we're not addressing the underlying cause of their malnutrition. So moving on to the must action plans, we had those different scores. This is taken from our care home malnutrition management pathway, bit of a mouthful. So it just helps it break down a bit more visually. So we've got the low score. So that's if they were already a healthy weight, or they've not lost very much or even gained weight recently. Those ones are low risk, routine care. You can continue monitoring them because they might have, they might be 4.8%. They might be losing weight, so they might need a little bit of support, but it's not a time to act and treat and prevent. It's more routine, and these ones do not need to be prescribed supplements at this stage. Just keep an eye, get to the bottom if there's any issues, try and manage those. And then if they're getting to that medium risk, so that's must scores of 1, again, we want to prevent it from getting worse. You can offer our Food First resources. We've got the links later on another slide. They might want to try over-the-counter ONS if they're really keen, but again, do not need to be prescribed supplements at that stage. They wouldn't meet criteria in the community to be prescribed ONS. And lastly, so must scores of 2. So you can get a must score of 2 from either being underweight, so a BMI of under 18.5, or significant weight loss of over 10%, or a bit of both. They might be slims, BMI of 18.5 to 20, and have lost 5 to 10% of their body weight. So 1 plus 1 gives them a must score of 2. Or they might even have higher. So this is must 2 and above. These are high risk. They need to be acted on. We need to prevent their malnutrition getting worse. We need to treat it, address those underlying causes, and make sure you're giving as much support as they need. So whatever the Food First advice is, that they can be given at home. If they can make up homemade milkshakes or have nourishing drinks before bed. We'll get into Food First. I'm getting carried away, but making sure we address it, and at that point they definitely can start ONS. So food, always our first port of call as dietitians and other clinicians. We always think food comes first. It can be done at home. It can be tailored, it can be preferred. So this is for all patients that are must score of 1 or above. They should be given some sort of food advice to prevent further weight loss. It should be the priority to make sure we give some sort of diet advice, and there's lots of different things that we can try. So that can be enriching their meals, it can be nourishing drinks, or homemade supplements. So in terms of what we suggest at Bob, we have a 1-2-3 method. So that amounts to 1 pint of fortified whole milk. And by that, I mean, well, it's 1 pint of milk, and then an extra step, you can add extra milk powder to the milk and make it extra nourishing. Step 2 is 2 extra high energy snacks or puddings a day. And 3 is aiming to have those 3 meals a day if they can, and with the added enrichment. And we'll cover what enrichment ideas you can try. We've got the standard resources there for that covers all of that, and the homemade milky drinks, but there's also alternatives if they need plant-based options, non-milky drinks or fruity versions. And we've got some resources on the over-the-counter supplements as well. And I just wanted to really point out that food first is quite, it can be easy and it doesn't have to be expensive. So we can get enough calories or as much protein as you can find in the prescribed bottles and shakes. So even just a quarter of a quiche or some mackerel on a slice of toast would be equivalent if they can obviously manage food. But there are some alternatives on screen. Tried to give a range. Some I know won't be as appetizing to an older resident or patient, but there are some options on there anyway. So there's some high calorie and some just smaller ones that they can add in. And when we talk about enrichment, over time it's always, you know, prioritized butter and sugar, things that you can add in easily, cream, milk powder and things like that. But we are trying to also still promote more nutrient dense foods, because it's not just about fat and sugar, but also about nutrition, and that will be more satisfying and a bit more nourishing for their bodies and their overall health. So you can also enrich with added grated cheese or ground nuts if they don't have any allergies. Smashed up dates as a lower sugar alternative to adding sugars, and milk powder can go in so many different things, just dissolves in, doesn't change flavour, but adds in a little bit of protein with each teaspoon or tablespoon that can be added. Can not just be added to your teas and coffees and milky drinks, but sauces, soups, custard, yogurts, anything liquid can add in milk powder. That was just a link to our resources. As I said, we have fruity versions of the milkshakes. We've got milk-free versions for vegans or dairy intolerant individuals. If you don't like sweet drinks, there's a suggestion there for how you can enrich a homemade soup. And there's also some resources for if they've got wounds, because protein needs are much higher with the open wound. And there's some high protein snacks and some suggestions for some purchasable over-the-counter products, and they can here can be purchased online. They can be available in supermarkets and in pharmacies. So there's lots of different options out there. I've updated the prices, but there are lots of different options for people to try whatever's available near them. So when we now come to supplements, we do suggest implementing a food first approach for a month, unless contraindicated. So if they can't do food first, or they're finding it difficult to eat for any sort of reason, that they have trouble swallowing or chewing, everything, all those other reasons, including like preparing food or they're not opening their mouth and things like that, then we would say skip that step. But for everyone else, at least to try with some enriching meals or some extra milky drinks and snacks. We'd suggest starting with a dose of 2 per day for the first line treatment, and if you can, use the sample services to see if they do actually tolerate them and can take them twice a day, because they've got to be taking it twice a day to have a benefit, to get enough extra energy in. And to find their preference, they've got to enjoy taking it. And there are lots of different products that they can try, which are here. So we've got this non-specialist formulary, previously known as the Quick Guide. Both links, the links are the same. So starting with either the AIM shake or the alternatives listed, the smaller version if they can't quite tolerate the big one. It's the same product, just made with less milk. And then there's smoothies, which are made with water and are milk-free, and a savoury option. And if there's any reason that they can't have a powder, can't make it up, or there's not a carer available to make it up, then we have listed the preferred first line bottles. They're the most cost effective and nutritionally equivalent to alternatives that you might be more familiar with. So Ouchplant Energy is first line, but there are some alternatives. You've got plant-based ones, and a little bit small for me to see actually. We've got some juice ones, and then compacts. So there's a little bit of a shift in our focus now. We are trying to promote hydration, and the only difference really between the standard size 200 mils and the compact size is just 75 millilitres less of water. They just take it out and charge you an extra nearly £1 per bottle to do that. So yes, if someone absolutely cannot take that much extra liquid, and they would struggle to comply, struggle to finish the bottles, but it's important that they gain their weight, then we've given some suggestions of the compact dailies. And these are essentially 2 compacts in 1 bottle, so a bit more environmentally friendly, and they cost cheaper than 2 bottles of the more familiar alternatives. So how do you choose an ONS for a patient? You want to take different things into consideration. So you want to make sure you're going with what the patient prefers, what they can tolerate, what they're likely to actually take. Obviously cost effective, because we're optimizing, and that's our team's job. And if they can take a powder or make it up, then opt for those. And we said they've got the savoury version, smoothie versions, milky versions, smaller versions. There are different ones to try, and there's different brands, so they all taste slightly different. So they can enjoy trying those. And then what's suitable for them. So are they actually able to consume 2? Would they struggle with that? Do you need to consider some alternative, like the smaller versions? Are there any contraindications or allergies? So key here, renal patients, for example, if they're stage 4 or 5 with chronic kidney disease, or they've got an eGFR of less than 25, they should not be prescribed powdered ONS. The micronutrient content is too high, and we do not want to mess with that, so they should be on bottles. Also, if they've got a lactose intolerance or dairy intolerance, then again, powders, because they're made up with milk, would not be appropriate, although they could have the smoothie ones. And you have to check for if the bottles are clinically lactose free, so that information is all on our formulary, including halal and kosher and vegan and vegetarian. All that suitability is included in our formulary. And then ensuring that the patient understands the importance of it, because sometimes it depends what conversation they had in the first place, but if you're having the conversation, then you can make sure that they understand that it is a short-term intervention to meet an agreed goal, and you can decide that goal with them, because it's really establishing what the worry is and who is worried. So, you know, are they worried that they no longer have the energy to do their activities of daily living, or and they need that extra support, or because I think as clinicians we're more worried about the stats and the data and the actual weight on the scale, but actually for them it's more about energy just to thrive and live. So having that conversation with them and setting what a goal would be, it doesn't have to be, they have to meet X amount of weight. We can move away from that and think more holistically about what would benefit them, but making sure it's got an agreed endpoint, so you know that when you come to review, you know quite confidently, yep, I've helped them, and you know when you can then discontinue it. And practically, they are a supplement. They're not meant to be a meal replacement. They can be stored in the fridge. So if you think about that compact bottle, it's 2 compacts in 1. They don't have to drink both all in one go. They can have some, put it in the fridge, have it later again if they want more, and have their second dose. And we do have a fact sheet for patients that explains a bit more about the ONS treatment they've been given, what they should expect, what they need to watch out for, how they can monitor themselves, and that sort of thing. So that's a useful resource to give them. Just to give Sarah a bit more warning, I will talk about reviewing ONS, and then perhaps Sarah can take on if she's around for case studies. Moving on. So in terms of reviewing ONS, we often see that they are left on, you know, they started and carried on. And that can be because there's just a lack of goal. You know, when do we stop it? There's not been a goal set of we'll stop it at this point. We know that we've helped. So that is important, and that can be reviewed and reassessed in 4 weeks. You know, how are we getting on with this goal? Are we progressing towards it? Do we need to revisit the treatment? At that point, you can check their weight, check their MUST score, see if it's improving, check if they're actually taking it. You can look at the dispensing rates, see if they're actually issuing it around the same time every month. If they're taking it less, that means they're not obviously taking it. And then when it's time to escalate. So a bit more in depth in terms of what you might do depending on their updated MUST score. So if it's low risk or a medium risk, they would no longer meet criteria for ONS on their prescription. So at that point, you would have that conversation around stopping ONS. And that's a challenging conversation. That's the future of our webinars. We'll go into covering how you can address that when it creates a bit of anxiety or agitation. But that would be the point that you would stop, and reassure that you will continue to monitor if they do lose weight or they deteriorate again, that you will always be there to help, review and revisit the situation, decide what else might work as an alternative tool for managing their malnutrition. If their must score is still high or has become high, then revisit that aim. It might no longer be appropriate if they're end of life, palliative. It might not be that nutrition intervention at that time is the most appropriate plan. Or it might be that they've now reached this just new baseline, that they just might always be slim, but they're at least stable and they're eating well and they're not worried, they're managing. So just having that conversation, just a score of 2 doesn't always mean act. You have to really take it on a case-by-case basis. But if you are concerned, definitely escalate. And then lastly, when you're completing your nutritionist assessment, again, just checking if they've been stable, so that new baseline, and having that conversation around the ONS. It's been it might have been a month of taking it, might have been 2 to 3 months taking it. Are they still enjoying them? Are they still able to take them 2 times a day? Are they struggling now? They've reached taste fatigue. They might need to try something different. Are they actually benefiting the patient? That's a conversation to have, and you can use that opportunity to go over your food first again, or perhaps try something different or escalate as you need to. So Sarah will share some case studies.
Yeah, so just before we go on to the case studies, is there any questions, or if you would prefer not to talk, please put anything in the chat if we haven't clearly explained anything, or if you've got any patients that you would like to discuss. So the first case study that we've got here is a 70-year-old lady. She's recently been discharged from hospital on Ensure Compact twice a day, and Naomi mentioned earlier in the conversation, the Ensure Compacts are more expensive, but they say they contain the equivalent amount of nutrition of our 200ml serving supplements. So the equivalent would be Ensure Plus Milkshake, which is no longer on the formulary. So we would be looking at a product called Ultraplen Energy, which would be the direct switch. Her weight has ranged from a current weight of 7 stone, so 50 kilos, to 8 stone, 52 kilos all her life, and she's not had any recent weight loss. So when we look at completing a must score for this lady, she has a BMI of 18.3 and her must score is 2 because her BMI is less than 20, but she hasn't had any weight loss. She's now returned home where she's independent, she gets meals delivered, she's reporting to eating her usual amount, she's unsure why she was put on Ensures, and she's not concerned about her weight, and she's always been small. She hasn't been taking 2 per day anyway, she's only been taking the 1. What are your thoughts? What would you do? Anybody feeling brave? Okay. So what we would look at here is the anthropometric shows that she's her usual weight. So her BMI has always been around 18. Her current food take is showing that she's eating usual amounts. She's got no concerns relating to her appetite. She is independent with food prep, although she's getting her meals delivered. And her compliance with her Ensure, her ONS, she hasn't been compliant. She's only been taking once a day. So in this situation, we would say it's inappropriate to discontinue the oral nutritional supplements. Yes, her must score is 2, but that's usual for her, and we've taken into account what her normal weight history is. And we would suggest advising her on the importance of monitoring her weight and also methods for increasing her food intake by around 300 calories per day, and reiterating or safety netting really if she does notice that she starts losing weight to come back to the surgery and seek further support. Okay, we'll move on to the next case study then. So we have an 80-year-old male with dementia who lives alone but has carers. They come in 3 times a day to help with meals and hygiene. The patient's daughter also lives nearby and pops in daily. The patient is bedbound. They're under the community nurses for pressure sore management. They've been prescribed Ensure Plus Advanced twice a day since 2021, so they've been on it for quite a while. And the reason for the initiation was a hip fracture, and it was started during their hospital admission. The last weight on your system is 59 kilos, and that was probably from that, I would say, hospital admission, because that weight is also from 2021, and their BMI was 18. What are your thoughts? What would you do? So what we would suggest looking at here is, in terms of anthropometrics, there's been no weight since 2021, but they are being seen by the community nurses, and community nurses have an obligation to nutritionally screen anybody that's on their caseload. So it would be helpful to link in with them. It's likely that they too won't have a weight, but they should have been completing a mid-upper arm circumference to support completion of MUST, as that person is bedbound. It would also be helpful to speak with the patient's daughter to understand what their opinion is about their father's weight. And obviously we need consent to have those conversations with relatives, and thinking about subjective measures as well. So it'd be useful to understand from both the daughter, if you have consent, and from the nursing team, what are their opinions about this gentleman's nutritional status. So understanding what their typical eating routine would be important. The ability to implement a food first approach, it would again be important to speak with the daughter and understand what are the opportunities, and to give some ideas and suggestions based on that feedback. They're also having carers, so if carers have clear plans and advice on how to support residents, they should also be supporting this person to achieve extra nutrition via their diet. And there may be an opportunity to switch to homemade supplements rather than being on prescribed ones. So you'd need to weigh up all of that information from your assessment. It would be helpful to also understand, actually, as this gentleman's been on the supplements for such a long time, are they still compliant with them, and what is the actual dosage that they're managing? So depending on the information collected from the nurses and daughter, you would need to use that to ascertain if the ONS is appropriate. If it is appropriate, as they are having carers, we would suggest switching to a powdered or a nutritional supplement, so that's something like the AIM Shake product. If it's inappropriate, we would suggest providing food first advice, stopping and reminding again the family to seek support, or the nurse to seek support from the practice should there be any further concerns about the patient's nutritional status. If we go on to the next one then, so we've got case study 3. We have a 50-year-old male prescribed Ensure Plus milkshake, started 5 years ago by a dietitian during treatment for head and neck cancer. They're now in remission. Their weight was 75 kilos. Their BMI was 24 pre-diagnosis. Since remission, they've been able to maintain their weight at 67 kilos, and their BMI is now 21. They take Ensure Plus 4 times a week. They use it on the odd days here and there, and tends to use it on the days where they go for a long walk. The patient says they have a poor appetite and they don't want to stop their ONS as they rely on them to keep their weight stable. Their eating and drinking has never been the same since their cancer treatment. They don't produce enough saliva in their mouth, and they have to follow a soft diet, and they don't really enjoy eating anymore. So they eat because they have to, and it's no longer an enjoyable part of their day. So what are the thoughts? What could we do for this particular gentleman? So again, if we have a look at the anthropometrics, it's showing that their BMI is 21. They have a weight of 67 kilos, so they're a stable weight. With their current food intake, I guess it's important to acknowledge that the person has a more limited diet following their cancer treatment. However, they are maintaining their weight, which does indicate they are able to eat and drink enough orally. They are only using their ONS on a very ad hoc basis, so I wouldn't suggest a full-time a week usage would be the factor that's supporting that patient to maintain their weight. They can implement a food first approach, although they may be reluctant to consider that. So it can be challenging when a patient relates their weight maintenance to their ONS consumption, despite usage being minimal. We would advise their BMI is now within a healthy range, that it's no longer clinically indicated, and acknowledge the challenges with their eating following their cancer diagnosis. In these ones, it can be quite a sensitive topic, obviously, to stop that ONS prescription, as the patient has a considerable reliance on them. So we would suggest negotiating with the patient and weaning off. And it may be that you think, oh, they're only having 4 bottles a week, but psychologically for some patients, it can be a real change to have to come off that prescription. So I would negotiate with them to have 1 further prescription, and ask them to reduce their usage down to, say, 2 a week, to support them to get used to the idea of coming off the oral nutritional supplements. So I'll just hand back to Naomi now, just to do the final points, if that's okay.
just in summary, some just key points to remember. So we've covered a lot today, but if you're just wanting to make sure that you do make sure they cover some food first advice for a month if they can do before considering the ONS. It doesn't, food should be the first port of call, not just supplements. Already linked a lot to our recipes and our food fortification resources, and they are on our open website, so they can be shared directly with patients. And then if they are complex at all, so if they've got dysphagia, if they're diabetic, if they have a kidney disease and they're high risk of malnutrition, then they're probably better suited to be seen to by a community dietitian, and we have got contact details for them at the end. ONS should only be prescribed if, as we said, food first for at least a month and they're still deteriorating, and they have that high risk of malnutrition, or subjectively it looks like they're still high risk of malnutrition, and the ACBS criteria, so usually disease-related malnutrition is the key one, or they've got some sort of obstructive condition, they're then absorbing their food very well, or they've got a swallowing problem. Then we should always suggest powdered first if they can make up a shake or have a carer available to make up a shake. And if that is the case, then they wouldn't necessarily be eligible for a bottled ONS. And a reminder that they are just a supplement and not a substitute or a replacement. And they should carry on, if they are doing any sort of food first methods, they should carry on side, because if they're still losing weight on food first, you're adding supplements on top to try and prevent malnutrition. If they then go back to not eating very much, then you're not going to promote that weight gain. You definitely want to have that clear goal. As we said, you want to know when, how do you know if you've helped, setting that clearly, and then NICE guidance is a 2 to 3 month review. And that should be added whoever works well in your clinical system. So whether that's directly in the dosage box, whether that's a calendar reminder, whether that's however works. Really, it just depends on how the system works for you. So making sure there is a way to flag them up that they need a review, and deciding whether they can be discontinued if they're no longer having a benefit, if they're not continuing them, if they're not wanting them. Those are also situations where you stop them because they're not really having a benefit. And we've said how there's some over-the-counter versions where they can purchase alternatives. So that might be a way to negotiate coming off them, that they can purchase them themselves when they no longer meet the prescribable criteria for them, as a way to reassure them that they'll still be getting some extra nutrition, but taking some responsibility for getting it themselves. If they're in a care home, so currently Oxfordshire do not recommend prescribing of supplements in care homes unless there's exception criteria that are met. There is a care home support service that can support with some nutrition and hydration advice. We have a care home support service in Berkshire, and there's dietetic services in both Berkshire and Buckinghamshire that can also offer support for care home residents. They try and give a bit more of a holistic approach and give some bespoke advice for that patient. And because they have got carers available to make up powders, they should only really ever be prescribed powdered ONS if they are a resident of a care home, unless there is a clinical reason why that's not suitable. If they're coming out of hospital, we've done a lot of audit work locally to show that for the most part, 95% of patients that are not really high risk of malnutrition, they don't still need ONS once they're back home, back to their baseline, eating their familiar foods again, recovered from their illness. 2 weeks after discharge, 95% are actually okay and don't need to keep having them. So if they've come out on the TTOs, you probably can feel quite confident just stopping them, but perhaps reassuring the patient if they are deteriorating or have any concerns that they can reach out and have an appointment. And we do have, if you do feel like they should be continued, and then just definitely switch them over to our formulary alternatives, because in hospital they're really limited with what they can choose, because they have agreements with what they can keep in stock from a space point of view and contract point of view, whereas at home we've got this whole formulary of alternative flavours and things that they can try to find something that actually works better for them. Now, obviously, it's not just practices starting prescriptions or requesting prescriptions. It can come from other healthcare professionals, nurses, palliative care team, frailty teams, patients themselves, relatives. There's lots of people, and they might say, can I have some Ensures please, because that's the most familiar product, or they might say some Fortisip or something else. But we have a formulary for the most appropriate options. So if they are requesting that, it doesn't mean they need that one. They are usually, the ones that we put on the formulary are clinically equivalent, nutritionally equivalent, just as good. And so they can try something else, and it's setting that expectation that just because they have had that product before, they might be transitioned onto something else now they're at home. But it's just as good. We'll still meet their needs, we'll still meet their goals. If they do happen to deteriorate for some random reason, then they can come back to you and you can have a conversation about why and seeing if there's an alternative that they can try. And the contact details for our team, so always just message the team inbox to make sure one of us can pick it up, which is the bobicb.medicines@nhs.net. We can give advice on bespoke patients. We usually ask that PID is removed for our team, but if we need to help, we can have an arrangement. And then the community dietitian contact information. And as a last reminder, our next topic will be a bit more in depth on ONS prescribing in care homes. The link is the same, so if you add it to your calendar, it'll be the same link each time, and it'll be on Tuesday, the 22nd of July at 1 p.m. Any final questions or anything anyone wants to add?
There was just a topic in the chat. So somebody's asked, are paediatric patients included in the PQS target? So what you will find is that the ONS, the non-preferred ONS that we're targeting as part of the PQS scheme, are all adult oral nutritional supplements. But I would say sometimes we do get look-alike, sound-alike errors for oral nutritional supplements. As I'm sure you're aware, they're all very similar names. So sometimes we do find that children may accidentally be prescribed an adult oral nutritional supplement. Or the other exception could be if they're an older child. We do say in some instances you can use an adult oral adult ONS for a paediatric patient, and that will be determined by the patient's age and or their weight. So it's that's quite niche, and we don't see it a lot of time, but you may see some look-alike, sound-alike errors. And if you're not sure, you can reach out to Naomi and I via the medicines inbox if you need any help or advice. So if you're not sure about any of the oral nutritional supplement prescribing, and also for any nutritional borderline substance prescribing, Naomi and I are here to help and support. So please do reach out with your questions and queries. I hope that's okay, Morag. So if there's no other questions, we'll probably end it there today. But if there's anything that you do want to cover in any other sessions, please do reach out and let us know, and we will try and tailor our sessions to make it as practical as possible. So thank you for your time today.